So I am Shashi Khandavalli. I'm a GP in Chorley, as Juliet just mentioned, I'm a clinical director for the Chorley Central Primary Care Network and clinical advisor placed at Central and West Lancashire for population health. And I've got three sort of main objectives for my talk today. So hopefully relatively simple. I want to give you key principles of success in collaboration. I don't want to, it's not to replace what Jen has said before, which is, fantastic knowledge base there, with a deep level of research behind all of that, but hopefully can bring out some of the key principles of success that we've learned from our work in collaboration across our organizational boundaries. Examples of partnership working that we've done in Chorley and Central Lancashire, but also across now as we scaled up across the ICB, so that's Lancashire and South Cumbria. And that's the sort of the third part of this, so how we've taken up a scaled up approach, working all the way from key principles through our learning through our examples, and then bring this up at scale. So just a little bit about myself. This is a photo of me aged around 8. I grew up in Huyton in Liverpool, and my dad was a GP in Liverpool over 30 years. As you know, a lot of delegates on the call today know that Huyton is one of the most deprived areas of Liverpool, but also in the UK. And he was a GP there for over 30 years, and he absolutely loved his job. At the core, he loved being deeply integrated in the community that he served. And that's the core of primary care. You'll see in the corner here, classic 1980s telephone, and that telephone would ring 7 days a week, 365 days a year. He did a Saturday morning surgery, and we'd have patients calling, at 9 o'clock at night, and I'd answer the phone. Dad, there's a patient on the phone for him, and he'd go and do a late visit. So it was incredible hard work that he did, but he loved every moment of it. And as I say, at its core, it was being deeply integrated with his communities that he was serving. So I became a GP myself, and I never regretted the decision. But I had an affinity for management, so I enrolled myself on an MBA. And on that MBA, my research project was how to do cross primary care, so across the organizational boundaries in primary care, so in between practices, how you could do alliance working across primary care, hence what are now primary care networks. And it's those key factors of success that hopefully I've brought out in my work that I've done, and hopefully I'm going to be able to share that today. So the first one, and interestingly, it came across in the breakout room, but also before, was to define the goal. It's incredibly important. So we had an aligned way of working, that we were all working towards the same thing. And in our area, so what we're trying to do when we're working across primary care, but also with our wider partners, it was to improve the health and well-being of our population through the reduction in inequalities. And it's that word "through" which is really important here, because there's a lot of work going on around population health and population health management. And then there's a lot of work around health inequalities, and almost being as if they're two separate agendas, but they're not. Because the most efficient way of improving the health and well-being of your population is through inequality reduction. So this is not an ideological standpoint that I'm taking here. It's merely just what is the most efficient way to improve population health. And when we did this, when we had that deep discussion with all of our stakeholders, everybody was aligned to that, because they all agreed that the most efficient way of improving population health was through inequality reduction. And when we're talking about inequality reduction, we're talking about what causes inequalities. We know that it's to do with what some people term the wider determinants. So that's housing, that's income, that's poverty, that's social isolation, lack of availability of good nutrition, education for our children, and the opportunities for working. Those aren't wider determinants the way that I look at it. And it may be semantics, but I think it's really important not to call them wider determinants, because it almost gives license to our leaders to say, it's something we can deal with later, because we've got to deal with our core issues first, and then we'll come on to the wider issues. They're not wider issues. If they're accounting for 80% of health and well-being outcomes, they're the core determinants of health. And I bang on about this a lot, because I think it's so important, especially when you're working across organizational boundaries and trying to get people to work in an aligned way and making the same, what I call opportunity cost decisions. So they're making the same choices of what to invest in and what not to invest in. And by the very nature, we're talking about issues that sit outside the clinical consulting room. They require a deep participatory approach with our communities and those agencies that are serving them. Because if we want to get into issues such as poverty and housing, that isn't done through the purview of the NHS and a health lens. That's done with deep participatory approaches with wider agencies. The third key principle is that knowledge is the most valuable resource that we have, and knowledge management is the most valuable capability. I think we can sometimes get hung up on estates and buildings and, where does resource sit? But actually, we don't focus on what the most important resource that we have to harness, and that is knowledge. And what do I mean by knowledge? I mean knowledge about our individuals and the communities in which they live. It's that knowledge and knowledge about them which is the most valuable. And within that, we have two types of knowledge, really, don't we? We have explicit knowledge, which is like data, and we get really hung up on data. But that's only 10% of the story. The most important knowledge that we have to harness is tacit knowledge. That's that deep knowledge that resides within us. That's sometimes hard to codify, hard to write down, hard to put in a guidebook or to document down. That tacit knowledge is when my receptionist comes and knocks on my door and says, "Dr. K, Mrs. Jones, I don't know what it is. Something's just not right. She's never been like this when she comes to collect a prescription. Can you give her a call?" Now that knowledge, you can spend billions on an AI tech solution trying to find, where people put in their symptoms. It'll never capture that. It'll never capture that. That is tacit knowledge, and harnessing that is the most important thing that we should be doing, because that's when you understand true needs. And when you understand true need, you can match resources and capabilities to those needs. The fourth principle, and I hope I've not labored this too much going through the principles, but I think it's just so important, is that the higher the level in the system does only what it can do. Bit of a word salad. But I find that when we when we try and scale up our approaches and we try and do things, especially when we in the new world of ICBs, that what we end up doing is we start centralizing power and getting further and further away from our communities and our residents. That's where the knowledge resides. That's the most important knowledge we have to harness. And yet, as we start to scale, we get further and further away from our populations. When we do that, we develop care models that are ossified and are non-responsive to true need. So these are the four principles that I think are incredibly important, especially if we want to work across our organizational boundaries. So how have we put these principles into action? We've done this, I just wanted to say, we've done this over a number of years. One of the things that was mentioned in the first part of the talk came out a little bit in the breakout rooms. These principles, to embed them, to get them working, take a long time, because by their very nature, we're talking about working across, not just internally within our organizations, so trying to get our organizations to look outwards, to want to work with partners, but then to build those deep relationships across our organizational boundaries and with our communities. That takes time. One of the biggest barriers within that is trust. And we've done a lot of work on this. We've, going back to the original point about the core determinants of health, our partners to tackle those issues sit outside of our clinical consulting rooms. Therefore, we had to work with our community assets. And part of that is just, who are our community assets? Do we know who works and serves our communities, and how can we work with them better? So we've done a number of health activation events. This particular one was focused on movement, mindfulness, nutrition, and relaxation, and so we tried to work with partners, and we sourced through our council, who we have a very close relationship with, to find out who those community assets were, whether it be groups that work with people who have Parkinson's and helping them move, people who work with young children and young families, or those who work with people who have dementia, such as singing groups and walking groups, people who struggle with their mobility. We had a group called Steady On, who actually fixed walking sticks. I had no idea that there were assets out there that worked with our communities in such a way. One of the most important things we learned from this day on these types of events was not necessarily the community understanding who was serving them, but was actually the services talking to each other. One of the best feedbacks we had, which was from a number of our people presenting on these occasions, is just that, wow, we didn't even know that there was another dementia group in the area. And we've made connections. We're going to look to work together. So as we started to harness and understand who our assets were, we then started to put in more focused projects. So this one you may have heard of. This was the BINS project. So basically, we looked at people who are moderately frail, who were middle-aged, between the age of 45 and 60, and who were high attenders of primary care. And what we did was we said, well, who are these residents? What do they, what are their needs, and how can we sort of match resources better for them? So we first of all did a data exercise to pull in data, not just from our primary care records, and not just from our secondary care data that we could pull and identify at the resident level, but also across emergency care. And then we went wider, we went into our local authority data, and we were able to identify that those residents who are in this age group, who are moderately frail, also a high proportion of them asked the council to take their bins out for them, called assisted bins. This goes back to a point mentioned by Jen in the first talk around common language, and that was my learning point from this, is that the data and pulling that data together helped us form a common language. So a resident who had moderate frailty, and I may view them as somebody who's moderately frail or a high attender, actually the council view them as somebody who needs their bins collecting. But actually we're talking about the same resident, just through different lenses. And actually we can have a collaborative way of working around these residents. And that's actually what we've done. So with our council, we've set up a social prescribing service on the back of this work, because what we found through this work was if you match resources and capabilities much more closely to the needs that we identify, well, we work in a very different way. And we've set up a social prescribing service that tackles things like social isolation, financial problems, housing issues. A significant number of our residents, not just in this project, but time and again in different projects that we've done, have housing needs. Whether it be damp or mold, or that the housing is inadequate in some form or another, or whether it needs basic repairs. These are the types of things that we've been uncovering through our collaborative cross-sector working. Using data, we've now started to do, well, not just now, over the last 4 to 5 years, actually, we've been doing working with specific cohorts who have vulnerabilities. And we do work in an extended MDT methodology around these residents. So this is across the 6 practices that are in our network, so a population of about 55,000 residents. And then we use data to identify vulnerable cohorts, whether that be high intensity use of primary care, whether it be frailty, or whether it's to do with that they have some safeguarding issues. And when we have so we have a safe, secure and legal data sharing agreement across not just our primary care partners, but also with our council and the local assets and the teams that are working with our residents. And we have consent from our residents to talk about their cases. And so we have the drug and alcohol team, district nursing, the wellbeing service, the fire service, carer support, social services, and we can talk about our residents and start to understand their needs better with our social prescribers, who then do a one-to-one holistic assessment to really understand and uncover those issues that are affecting them in their life. And then we can match resources much more closely to those real needs rather than what we think they require. So this is at our network level. Now scaling upwards across central Lancashire, we started to say, how do we utilize some of these key principles and some of these methodologies that we utilized previously? How can we start doing this at a much more scaled up version right across all of the networks, but at the same time, always focusing on the core determinants of health? So we've looked at respiratory illness, and we know that it's a compelling area to look at. When you look at life expectancy and healthy life expectancy, and you look at the difference in life expectancy and healthy life expectancy between our least and most deprived in our communities, we know that there are certain conditions that predominantly affect that difference. Number one is actually circulatory disease, but second on that list is respiratory disease, in particular asthma, COPD, as well as things like influenza, flu uptake. So we know that this has a significant impact on residents, especially in areas of deprivation, who suffer poor health, early death, or significant morbidity. And the cost to the NHS is astronomical, especially during winter when admissions are much higher. So knowing that there's a compelling reason that we needed to focus on these residents, we were able to work across our partners, not just in primary care, but also wider assets, including our social prescribers and our council teams, because we knew that if we really wanted to affect the outcomes of these residents, we needed to do things differently. We can't just focus on bringing in residents to have a medication review done, although that's incredibly important, or to ask them to have an annual respiratory review done, although that's incredibly important. We know that if these residents are experiencing poor outcomes, a lot of it is to do with their lived environment and the places in which they live. So these core determinants of health, and we have to address those as well. We knew that we also must have achieved an approach that focuses on those with poor outcomes, and we need to do it so in a way that's aligned to high clinical targets and high clinical standards in an evidence-based way. But we needed to overcome the same issues that we've talked about before. So what infrastructural problems are there? What intelligence issues are there? And what problems do we have to overcome when we want to do an intervention? So the information governance risks, whilst we had done overcome this in our network, there was an issue of trust across the networks. Again, echoing some of the learning that we need to take away from today is how we build that trust. So other networks would say, yeah, it's okay for you, but we're not so sure we're happy with that information governance agreement that you've got. It meant that there was a lot of checking over when you're looking at 8 networks. But we managed to overcome that. Have we got the right stakeholders involved? So who needs to be involved in this? We did spend a long time actually on stakeholder mapping, not just at the clinical aspect, but then also into our community assets. And then how do we identify which residents are most at risk? Like, what are the right filters that we put on the data? And remember, data is only 10% of the story. You can put a filter on, but miss key residents because the data is either incomplete or the filter that you use is it's not nuanced enough. And how can we harness the tacit knowledge that resides in our nursing teams and our clinical teams that serve these patients and know who those at-risk residents were? So we looked at residents who were across all the age groups, but had a greater than 50% chance of admission in a 12-month period, and lived in areas of deprivation. And what we did was we said we absolutely needed high-level clinical interventions across annual and medication reviews, but also vaccination. But we needed to do so in a way that understood those residents. So we used a personalized care approach through care coordinators. And those care coordinators were able to refer on to social prescribers to tackle social vulnerability, but also to gain trust with those residents. And so what we found was that it was meant to be a winter project, and as always, winter projects only start in January, but we were able to get a significant uptick in flu uptake. Now, most of these residents should have had their flu jabs by that point anyway, and the most vulnerable, but yet we were able to show a significant uptake in flu vaccination. The point I'm trying to get across here is that this is about harnessing tacit knowledge. This is about gaining trust with our residents, but also working with wider partners in that similar way. And as I said, we had an improvement in our clinical interventions, and we were able to surface significant social themes about issues that were affecting our residents. So we knew that 31% had mental or well-being or mental health issues, 33% struggling with their housing, and so on. And we were able to match resources to those needs. I've got 2 minutes left, so I'm going to talk a little bit now about taking these principles that I've said that from the ground up, we've worked this through our networks, then through specific projects, then are scaled up across central Lancashire. And now we're working across the system. And what we're really looking at is this model here. We're looking at how do we create environments where our residents can live and the circumstances that they're living in and improve those. How do we predict where ill health is going to occur and where people are going to suffer worse outcomes? How do we prevent that? How do we detect ill health if it has occurred? How do we work in a cross-sector and collaborative way to protect those residents and then manage and help them recover if they do suffer further problems going down? And in the centre is the key point. We need to coordinate. We need to coordinate across all of our partners. And part of that coordination problem, and it is a problem, is who does what. Because if we're saying population health is the problem of it, is an issue for everyone, is it an issue for everyone and therefore nobody's accountable or responsible for it? How do we work in a way that we know that we have to tackle all of these issues, but at times there are things that we need to do, and at times there are things that we need to help with. And that's what this model or this slide is hopefully trying to conceptualize and help us work in a coordinated way with our partners. Because there are times where, on the left-hand side, the green arrow is what our population health team is in charge of, which is from create down to detect. And then there are clinical disease pathway delivery boards, which is the green arrow on the right, going bottom up, who are going to be in charge of delivery on certain areas. And how does primary care find a role across all of that? So hopefully I've given you an insight to the key principles that we work towards, how we've harnessed knowledge across the life course, and some fundamental questions. I said 4 here, but I haven't gone through the 4 questions. Some fundamental questions that we've applied, and then a strategic approach across the system. Thank you very much.